Hi, hello everyone. Welcome to Dr. Ravichandra Official. Please like, share, and subscribe Dr. Ravichandra Official for more interesting videos on pathology. Today, in this video, we will discuss a interesting topic which is very common in India, that is tuberculosis. It is a chronic granulomatous inflammatory infectious disease caused by a organism Mycobacterium tuberculosis in humans. And it is also called as tubercle bacillus or cox bacillus, and it causes tuberculosis in the lungs and other tissues of the human body. And it is a strict aerobe and thrives best in tissues with high oxygen tension, such as in the apex of the lung. So the most commonest place where tuberculosis occurs is apex of the lung. This can be asked in the MCQ. Out of the various pathological strains for human disease included in Mycobacterium tuberculosis complex, the most common one currently is Mycobacterium tuberculosis hominis, which is a human strain. Coming to the bovine strain, Mycobacterium tuberculosis bovis used to be the common pathogen to human beings during the era of the consumption of unpasteurized milk. But nowadays, everyone is pasteurizing the milk, right? So it presently constitutes a small number of human cases. And next coming eh, is avian or bird strain, which is infection with Mycobacterium avium intercellular. It is common in patients with HIV or AIDS. So this is a beautiful picture showing the Mycobacterium tuberculosis, which is having a waxy cell wall and made up of mycolic acid, and it is a acid fast bacillus, and it can be stained using Gill Nielsen staining, where it is shown as rod-like structures which are in bright red color. Coming to the risk factors for tuberculosis, it is more common in Asia, African, and late Latin America. And malnutrition, inadequate medical care, poverty, crowding, chronic debilitating conditions like uncontrolled diabetes, alcoholism, and immunocompromised states are all acting as risk factors for tuberculosis. Mode of transmission, human beings acquire the infection with tuberculous bacillus by many routes. Out of them, the most common is inhalation of the organisms present in the fresh cough droplets in the dried sputum from an open case of pulmonary tuberculosis. Other spread is it is ingestion of the organisms leading to the development of tonsillar tuberculosis or intestinal tuberculosis. It, inoculation of the organisms into the skin may rarely occur from an infected post-mortem tissue also. Transplantal route is resulted in the development of congenital tuberculosis in fetus from an infected mother, and it is a rare mode of the transmission. Sites where tuberculosis can be seen is most of the times it is pulmonary region constituting around 85%, and the extrapulmonary sites will be around 15%. Out of the extrapulmonary sites, the most commonest extrapulmonary site is lymph node. This can be asked in the MCQs or in the NEET PG exam. Okay, so lymph nodes are the most common extrapulmonary sites for Mycobacterium tuberculosis infection, and pulmonary region constitutes 85% of the tuberculosis cases. After the lymph nodes, GUT, bones, joints, intestines, meninges, skin, everything can be attacked by the Mycobacterium tuberculosis. In the exam, they will be asking you TB resistant organs. It is pancreas that is resistant to tuberculosis. Evolution of the tuberculosis. The sequence of events which takes place when tuberculous bacillus enters body will be when tuberculous bacillus has its entry into the body, it enters through the blood and the neutrophils are evoked initially, which are rapidly destroyed by the organism. Then they are attacked by the macrophages and T cells. If the tubercle bacilli are inhaled into the lung alveoli, macrophages predominating the picture from the beginning. They are called as alveolar macrophages. So, tubercle bacillus engulfment by the macrophages will happen. This will try to kill the bacteria, and if they are poorly digested because of the cell wall or something else, macrophages present the bacillus to the CD4 plus T lymphocytes. These will activated the lymphocytes and release lymphokines like interleukin 1 and 2 and interferon gamma and tumor necrosis factor alpha, which will cause activated macrophages transform into epithelioid cells which have a slipper shaped nucleus, characteristic feature of epithelioid cells, after 2 to 3 days. Some macrophages are unable to destroy the tubercle bacilli, will fuse together and form multinucleated chain cells. Around the mass or cluster of these epithelioid cells and few giant cells, a zone of lymphocytes and plasma cells is formed, which is further surrounded by fibroblasts. The lesion at this stage is called as hard tubercle due to the absence of central necrosis. In the exam, they may ask you to draw a neat label diagram of hard tubercle or draw a neat label diagram of a soft tubercle. Or they may ask you what is the difference between a hard tubercle and a soft tubercle. The main difference between a hard tubercle and the soft tubercle is absence of central necrosis. Absence of central necrosis relates to hard tubercle, whereas central necrosis is present in soft tubercle. That is well appreciated in the given diagram. Within 10 to 14 days, the center of the cellular mass begins to undergo caseous necrosis characterized by cheesy appearance and high lipid content. This stage is called soft tubercle, which is the hallmark of tuberculous lesion. So the hallmark of tubercle lesion is soft tubercle, and it is showing cheesy appearance and high lipid content, which are the characteristic features. So the neutrophils or the macrophages will engulf the Mycobacterium tuberculosis. If they are poorly degradable, then they will present it to macrophage. These macrophages try to digest the organism. If they are failed to digest, these macrophages will activate the CD4 plus T lymphocytes to release the interleukin 1, 2, tumor necrosis factor alpha and interferon gammas, and they result in conversion into epithelioid cells. These epithelioid cells will fuse to form a multinucleated giant cells. So there will be epithelioid cells, multinucleated giant cells. Around them there will be fibroblasts. This all together is called as a hard tubercle. If it is replaced in the center with a caseous necrosis in the center after 10 to 14 days, then it is called as a soft tubercle, which is a hallmark of tuberculosis. Coming to the fate of a tubercle. A fate of granuloma is variable. It can be converted into a cold abscess, it may convert into a sinus tract, or the size of the granuloma may increase, or it may undergo calcification. This was shown in the picture. Types of tuberculosis. Infection with tubercle bacillus is of mainly two types. One is primary and the other is secondary. Primary tuberculosis. When we call it as primary tuberculosis, this can be asked for a 6 marks question, or it can be asked as 3 marks question as Gons complex or childhood tuberculosis. The infection of an individual who has not been previously infected or immunized is called as primary tuberculosis or Gons complex or childhood tuberculosis. And the most commonly involved tissues for this primary complex or Gons complex are, first is lung and the second is hilar lymph nodes. The primary complex or Gons complex is the lesion produced in the tissues of portal of entry with foci in the draining lymphatic vessels and lymph nodes. So this primary complex or Gons complex can be asked for a 3 marks question. So I am repeating it again. Primary complex or Gons complex is a lesion produced in the tissues of portal of entry with its foci in the draining lymphatic vessels and lymph nodes. Fate of the primary tuberculosis, it can be fibrosed or calcified, or it may convert into a progressive primary tuberculosis or primary miliary tuberculosis or progressive secondary tuberculosis. Secondary tuberculosis. The infection of an individual who has been previously infected or sensitized is called as secondary tuberculosis or post-primary tuberculosis or reinfection of the tuberculosis or chronic tuberculosis. The infection may occur from the endogenous source, such as reactivation of the dormant primary complex or Gons complex, or exogenous source such as fresh dose of reinfection by a tubercle bacilli. Secondary tuberculosis almost occurs most commonly in the lungs. Coming to the fate of the secondary tuberculosis, the lesions may heal with fibrous scarring and calcification, or the lesion may produce progressive secondary pulmonary tuberculosis with pulmonary and extrapulmonary involvements. It can be causing fibrocaseous tuberculosis or tuberculous caseous pneumonia or miliary tuberculosis or tuberculous empyema, which is shown in the picture. Coming to the clinical features of a tuberculosis, there are systemic features like fever, night sweats, fatigue, loss of weight, and appetite, which are the characteristic features of a tuberculosis. And which the features which are referable to lung are there will be productive cough that will be more than 21 days, that is more than 3 weeks. Hemoptysis, that is coughing up blood. If we call hematemesis, then it is vomiting out blood. Here it is hemoptysis, coughing up the blood. Okay. Pleural effusion, dyspnea, and orthopnea. These are all the symptoms that are referable to the lungs. So the signs and symptoms of active tuberculosis can be coughing that lasts 3 or more weeks, coughing up the blood, fever, night sweats, fatigue, unintentional weight loss, chills, loss of appetite, chest pain or pain with breathing, that is dyspnea or coughing. Or there may be postural variation will cause respiratory distress called as orthopnea. Coming to the diagnosis of tuberculosis, it can be done by various tests. Out of them, the most important test is acid fast bacillus stain, AFB stain, or Gill-Nielsen stain, where we will take a sputum or aspirated material and we will stain with the AFB stain and using sulfuric acid, and there will be rod-like structure seen under the microscope. So it is categorized like present on the number of bacilli, graded. No AFB in 100 oil immersion fields, then it is negative, and the fields to be examined will be 100. If there are 1 to 9 AFB per 100 oil immersions, it is graded as scanty. 10 to 19 AFB per 100 oil immersions, 1 plus, and 1 to 10 AFB, 2 plus, and more than 10 AFB per oil immersion field will be 3 plus. Sputum sample of each patient was also sent for culture for Mycobacterium tuberculosis and drug specificity testing to first line anti-tubercular drugs by 1%. Mycobacterial culture using LJ medium, which is a very important medium for Mycobacterium tuberculosis. LJ medium for 4 to 8 weeks is used for culturing the Mycobacterium tuberculosis. There are molecular methods like polymerase chain reaction, complete hemogram. You can appreciate the lymphocytosis and raised ESR. There may be some radiographic procedures like chest X-ray, which is showing characteristic hilar nodules and other parenchymal changes, consolidation, etc. in the X-rays of a chest. Mantac skin test. This is an intradermal injection of 0.1 ml of tuberculoprotein, which is a purified protein derivative, also called as PPD. Delayed type of hypersensitivity develops in individuals who are having or have been previously infected with the tuberculosis infection, which is identified as an indurated area of more than 15 mm in 72 hours. So for Montax test to be positive, the induration should be more than 15 mm in 72 hours. That is, after the testing dose, 72 hours after that, if it is more than 15 mm, then it is Montax test positive. There may be false positives or false negatives. False positives seen in atypical mycobacterial infections and previous BCG vaccination. False negatives can be seen in weakened immune system, sarcoidosis conditions, and some viral infections and Hodgkin's disease. So the management can be done using HRZDS, that is isoniazid, rifampicin, pyrazinamide, butyl, streptomycin, that deals with your pharmacology. The dosage regimen will be, it can be given in intensive phase and a continuation phase. Intensive phase HREZ for 2 months and continuation phase for HRE with HRE for 4 months. There is a regime called as DOTS therapy, that is directly observed treatment, where there is a short course of directly observed treatment, which means a trained healthcare worker or other designated individual will provide the prescribed TB drugs and watches the patient swallow every dose. Multi-drug resistance. TB caused by strains of Mycobacterium tuberculosis are resistant to at least isoniazid and rifampicin, which are the most effective anti-tubercular drugs. Globally, around 3.6% are estimated to have multi-drug resistance tuberculosis. Almost 50% of these cases worldwide are estimated to occur in China and India. And there is a one more term called as extensive drug resistant tuberculosis, where there will be the tuberculosis caused by bacteria that are resistant not only to isoniazid and rifampicin as well as to fluoroquines and any second line anti-tuberculous injectable drugs like amikacin, kanamycin, or capreomycin. This is a tabular form showing the drug resistant tuberculosis, which is categorized as multi drug resistant TB, MDR TB, or extensive drug resistant TB, XDR TB, which were discussed earlier in the slides. Drug resistance can be caused by incorrect prescribing or irregular supply of the drug or patient's non-adherence and low grade quality of drugs. This can be reduced by DOTS therapy, directly observed treatment. Tuberculosis and HIV. This is a greatest combination I ever felt or seen. Worldwide, the number of people infected with both HIV and TB is rising day by day. The HIV virus will damage the body's immune system and accelerates the speed at which TB will progress from a harmless infection to a life-threatening condition. The estimated 10% activation of the dormant tuberculosis infection over the lifespan of an infected person has been increased to 10% activation in 1 year if HIV infection is superimposed. So, with HIV, 10% activation in 1 year is common. It is the opportunistic infection that most frequently kills HIV positive people. Coming to the epidemiological impact, reactivation of the latent infection. People who are infected with both HIV and TB are 25 to 30 times at more risk, are more likely to develop tuberculosis again than the people those who are infected with tuberculosis only. Primary infection, new tubercular infection in people with HIV can progress to active disease very quickly. And recurring infection in people who are cured of tuberculosis is common. What are all the preventive measures for tuberculosis? You have to wear masks, take BCG vaccines, regular medical follow-up, isolation of the patient, ventilation, natural sunlight, UV germicidal irradiation, protein high intake. Coming to the BCG vaccine, this can be asked in your, for 3 marks in your pediatrics or in general medicine or in your microbiology. So what is BCG? It is Bacillus calmette garin. It was first used in 1921. It is the only vaccine available till today for protection against the tuberculosis, and it is the most effective in protecting the children from the disease. How it is given? It is given intradermally 0.1 ml, and the duration of protection will be 15 to 20 years with efficacy of up to 80%. It should be given to all healthy infants as soon as possible after the birth, unless the child presented with symptomatic HIV infection. Thank you for patient listening. Please like, share, and subscribe Dr. Ravichandra Official for more interesting pathology videos.